In this section, we're going to be discussing the treatment of recurrent and multiply recurrent C. difficile infection. We're going to focus here on the antibiotic-based regimens, and we'll focus in separate sections on fecal microbiota transplantation. Here, we're going to talk about the options of switching the antibiotic, of giving vancomycin in a prolonged, tapered, and/or pulsed regimen, or using what's called a chaser after a standard vancomycin course. So let's focus in on what these things actually are. The first is simply switching the antimicrobial. And the only study that looked into this was a subgroup analysis from the original phase 3 trials comparing vancomycin with fidaxomicin. Within those trials, 16% of the population had had C. difficile within the prior 3 months. Therefore, when they either received vancomycin or fidaxomicin in the trial, they were being treated for a recurrence. Those that received vancomycin went on to recur 35.5% of the time, versus 19.7% in those that received fidaxomicin or difficile. Therefore, difficile seemed to be statistically significantly better for the treatment of an initial recurrence. And this is why fidaxomicin or difficile is one of the treatment options that's being recommended for initial recurrence of patients with C. difficile in the updated Infectious Disease Society of America guidelines. What about other treatment options? Vancomycin in a tapered and pulsed regimen is also recommended. What we mean by a taper is that we give a prolonged treatment course, at least 6 weeks, where we slowly decrease the dose of the vancomycin. A pulse is at the end of a taper typically, and it is where we give the vancomycin every 3rd day, with 2 intervening days of not giving an antimicrobial. And the reason for this is that it has to do with the life cycle of C. difficile, suppressing that life cycle as it proliferates and minimizing the risk for recurrence. And let's look at the data. This is one case series that was put out by Dr. Khanna at the Mayo Clinic in Rochester, Minnesota, looking at the efficacy or the ability of a vancomycin taper to suppress and wipe out C. difficile infection. He looked at 128 patients with multiply recurrent C. difficile who received the taper. Overall, 41% of those patients recurred. Not so good. However, when he compared those that received less than 6 weeks versus those that received more than 6 weeks, the group that received more than 6 weeks actually had a statistically significantly lower rate of recurrence, 37.0% versus 56.5%. And in fact, the length of the taper seems to matter a lot. So if we are to receive a vancomycin taper, more than 6 weeks is very, very important for you as the patient. What about how we finish the taper? As I mentioned before, we can simply finish the taper with every other day dosing, or we can finish with what's called a pulse, where we give every other day and then every 3rd day. And that's what Dr. Johnson looked at with this study. He looked at 36 patients that received every other day dosing and compared them with 64 patients who received every other day, followed by every 3rd day. And what he found was that the sustained clinical response, the ability of the treatment to wipe out the C. diff and keep it away, was 81% with the every other day followed by every 3rd day versus 61% in the every other day dosing. Therefore, for you as a patient, if you are to receive a vancomycin taper, you might want to have a discussion with your practitioner about receiving every other day followed by every 3rd day dosing at the end of that taper to try to maximize the ability to wipe out the C. difficile infection. What about giving a different antibiotic after a standard antibiotic course? And this is also something that is recommended within the IDSA guidelines for individuals that have 2 or more recurrences of C. difficile. The only prospective randomized control trial that has looked into this looked at a different antibiotic called rifaximin. Rifaximin is an antibiotic that stays within the lumen of our digestive tract. So we envision our digestive tract as a hollow tube. This stays within with minimal systemic absorption, minimal absorption into the blood, and has some efficacy against C. difficile. So in theory, this would be like giving a second punch after finishing the vancomycin course, a punch from a different angle. And that's what Kevin Gary did in this prospective randomized controlled trial, where patients were randomized to receive either rifaximin after a standard vancomycin course or placebo, and the chaser was given for 20 days. What Dr. Gary found was that those that received the rifaximin had a recurrence rate of 49% for their diarrhea versus 21% for diarrhea alone, and diarrhea with C. difficile positive stool assay was 31% versus 15% with the rifaximin. So we see that potentially giving another antibiotic like rifaximin might be a very effective treatment for multiply recurrent C. difficile. However, if we think about this, rifaximin is not an antibiotic that is specifically potent to C. difficile. However, fidaxomicin is, with minimal effect on the surrounding bacteria. So this is a case series of patients who either received fidaxomicin or difficile 200 milligrams twice daily for 10 days after a vancomycin treatment course. In those, the recurrence rates were 38%, not as good as we would have liked. However, in a group that received fidaxomicin or difficile in a atypical fashion, one tablet once daily for 7 days and every other day for 14, similar to another type of taper and then a pulse, we see the efficacy or the recurrence rate was pretty low. It was 18%. So this is a treatment that I in my practice typically will use. I will use a prolonged vancomycin taper up to 10 to 12 weeks, followed by a fidaxomicin chaser, giving one tablet once daily for 7 days and every other day for 26. For you as the patient, it's important for you to understand some of the treatment options from an antibiotic standpoint that could potentially give you the best option for cure. And your understanding of these treatments hopefully will open a healthy dialogue with your healthcare practitioner so that you get the most optimal treatment possible and, of course, the best outcome possible.